I would request the attention of the chairpersons. Please welcome for this session on dyslipidemia controversies to consensus. Each of the speaker will have 9 minutes, followed by 2 minutes of quick observation from the chair. Ladies and gentlemen, as this particular session is on invited basis, we will primarily confine the questions to the chair, and if time permits, the chair may offer it to the floor. To help the speakers be on time, we have a timer straight across. At the end of 9th minute, the slides of the speaker would be freezed with the timeout slide. So with these few words, may I straight away request our chairpersons, please welcome Drs. P.K. Khanna, Protasio Daluz, Sangram Birdar, S. Vithanavasam, J.S. Soin, Sanjay Sood, Sudhir Nagisetti, Anup Gupta, and S. Sharma. All the 4 speakers, Dr.Sarita Gulati, Professor Geeta Subramanian, Professor Sandeep Bansal, and Dr. Anil Kumar Virwani to kindly join the proceedings on the dais. Our opening speaker this afternoon is Dr. Sarita Gulati. She is a senior consultant cardiologist at the Moolchand Medicity from Delhi, and she'll be speaking on high dose versus low dose statin in coronary artery disease. What is appropriate? Dr. Sarita, please.
Good evening, respected chairpersons, ladies and gentlemen. Over the years, statins or HMG-CoA reductase inhibitors have really proved wonder drugs, as they have proved their mettle not only in secondary prevention of cardiovascular disease but also in the primary prevention. So far, we have been guided by National Cholesterol Education Program guidelines regarding the management of the lipids, which stratify the individuals into various risk categories depending upon the probability of getting a cardiovascular disease over the 10-year period, and direct the lipid-lowering therapy towards that. But what was found in the coming years was that the Framingham risk score used showed the observed risk was much more than the predicted risk. Moreover, most of the lipid lowering trials have used a fixed dose statin to to treat the people, and they are not specifically targeting specific LDL levels. There are various areas of inadequate evidence, or we can say where the things are still not clear. One is whether we should be titrating our LDL lowering drugs towards achieving a particular target, and then the question arises, what lowest target is the best for individual. Second is the use of non-LDL drugs, like the ones being raised for raising HDL or lowering triglycerides. So far, scientific data has failed to give any positive results regarding use of these drugs. Then we have certain clinical scenarios like end-stage cardiac failure or renal failure and elderly age groups where the things are not very clear. But the many trials, randomized trials, they have shown that wherever the intensity is concerned, high-intensity statins are faring better than the low-intensity statins. Keeping all this in mind, the ACC-AHA have come up with new set of guidelines which say that at least there are 4 groups which benefit from high-intensity statins, and according to that, in the adult more than 21 years of the age, if there is already a clinical evidence of atherosclerotic cardiovascular disease, or the LDL levels are more than 190 mg/cent, or the person has diabetes, we should be considering high intensity statins. If not being tolerated, then we can go for moderate intensity statins. And similarly, a group where we think that the 10-year predicted risk of cardiovascular disease is more than 7.5%, they should also be taken for moderate to high intensity statins. Now, what is this statin intensity we are talking of? The high intensity statins means that the dose which can reduce the LDL by more than 50%, and low intensity statin means which can reduce the LDL levels by 30%, and moderate comes in between. This is the pooled cohort analysis calculator which is being proposed by the ACC recently. If there is no clinical atherosclerotic coronary vascular disease, then we need to consider the people, we need to individualize the things. Here are certain subset where we should be strongly considering the high intensity statins, and but these are also the groups where we should have a doctor-patient counseling. The patient should be advised regarding what are the benefits, what are the adverse effects he can expect, and what is the cost effectiveness of these strategies. There is one group where the routine risk factors are not there, but we need to look for the surrogate markers for atherosclerosis. Like we need to consider if there is a family history of premature coronary artery disease in the people, if there is a history of familial dyslipidemia or the calcium, coronary calcium score. Similarly, there is a value of HSCRP level in such subgroups. So considering all this, will help us in deciding. Now, once we talk of high intensity statins, immediately to the clinician mind, many questions come up. What will be the side effects? What about the compliance? What is the cost effectiveness? And everything has a meaning. These are not without concerns also. Regarding the side effects of statins, the myopathy or the rhabdomyolysis is the incidence is very low, though high dose statins are a risk factor for such side effect, and one of the gene variant is also considered to be important in provoking myopathy or the rhabdomyolysis in a particular setup. One new side effect which is recently coming up and is seeking our attention is the onset of diabetes in such patients. Previously, the two meta-analyses, they showed that the incidence of diabetes was not that high, but one of the meta-analyses by Press et al. Has shown a 12% increased risk of diabetes with high dose statins. Now, should we be withdrawing statin from patients with the fear of diabetes in the mindset? No. The scientific literature so far says we need not to do that. The reasons are, first of all, statins benefit risk ratio is quite high. Then it has been seen that all those people who developed diabetes, they were already sitting on a volcano of that. This means they were already having metabolic syndrome and they were already having poor lifestyle management. So our precaution should be that we educate the person about the proper lifestyle. We educate the person to keep a check on the blood sugar levels and do not withdraw or stop statin from such subgroups. Regarding Indian subset, what is very important is that it is found that with the equivalent dose of statin, there are high plasma levels achieved with Indian people as compared to Caucasians. Iris studies showed that what is a 50% reduction with a moderate dose for the other population, we achieve with the same reduction. So what is a moderate dose for the other population is a high intensity dose for our people. And most of these statin trials, they have not included Asian people, Asian Indian populations. Predictive value of pooled cohort equation also has not been tested in Indian population. So we should be, another important aspect in Indians is that we have a high prevalence of metabolic syndrome, and the risk of diabetes is of course a factor to be considered. Cost effectiveness in primary prevention is another issue. This is not the, it's the last but not the least important issue. It is the most important issue in our setups. It is predicted that with the newer recommendations, even in US, they are targeting for more than 13 million new people for this statin. Now for the Indians, the recommendations are that we should be having our own data, the pharmacokinetics of the statins in our population. Then we should be having data regarding the adverse effect of statins in our population. What is the prevalence of gene variants which is important for developing myopathy, and of course the cost effectiveness of statin use in primary prevention of the disease. Thank you so much.
Congratulations. May I ask you one question? I want your personal opinion. Do you think that having a goal for treating patients would improve adherence or not? In other words, you see, I don't like the discussion of high or low.
Yeah.
I think the correct discussion is give the appropriate doses.
Yeah.
I don't know, it's like sugar in the coffee. Do you like high sugar or low sugar? No, I want the adequate sugar.
Yes. I fully agree with this thing that the ideal goal has to be maintained. This will not only ensure the compliance of the person, also we will be keeping a check what dose is required and how much is required. This is very, very important. Keeping the ideal goal in mind. I fully agree with that.
Okay. Thank you. Yeah, do we? Okay. Thank you very much, Dr.